So in 20 minutes, I'm going to try and just run through fairly quickly some current challenges, some newer things, as opposed to trying to teach you to suck eggs, which would be the wrong thing to do. The rather depressing situation is summarised here with respect to CDI rates, incidence during and since, if we are bold enough to say since, the pandemic. 25% increase, and that's following years of, at worst, plateau and at best, continuing decrease in incidence. So a 25% increase is very, very stark. That's predominantly, but not exclusively, because of hospital onset cases. So you can see the numbers there. What gets worse, and this is not working, it does now. What gets worse is that if you look at the mortality associated with C. diff, and yes, these are crude mortality data. So it's who is dead by day 28 after a diagnosis of C. diff infection. So the rate has been gradually decreasing. It was in the 20s%, and it decreased to about 13 point something %. And that's reversed from 13.5 to 14.9. You might think, well, that's not that much. Actually, it's a 10% increase, which is bad. And if you just stop to think, what's the mortality associated with meningococcal meningitis? Which I know is a million miles away from C. diff, but there's such a furore, isn't there, when there's a case of meningococcal meningitis or sepsis, and yet the mortality associated with meningococcal sepsis is less than this rate here, and it's going in the wrong direction. And it's worse if you've had a COVID diagnosis in the 28 days before or the 28 days after the C. diff infection diagnosis. And yes, that's partly because the elderly do badly from C. diff and they do badly from COVID, but there may well be an interaction as well. So we could speculate till the cows come home about why that's happened, and I'll show you some data briefly to show that the C. diff strains have not changed. We don't think quantitatively antibiotic prescribing has changed. We've got data on that, and there's no good evidence that qualitatively has it changed to account for a 25% increase. What I simply think has happened, simply but depressingly, and this is not pointing fingers, is that we have concentrated for very good reasons on the control of a respiratory virus as opposed to an enteric pathogen. And there are fundamentally different control mechanisms, which of course we're all aware. But when a system is creaking, and some might say that the NHS is creaking, then C. diff is very good at exploiting such creaks. So you can see here across before, during, emerging from the pandemic, the types of C. diff, the ribotypes of C. diff, have not changed. So these patterns are essentially the same. There are very marginal differences, but there's not an appearance of a particular ribotype or an expansion of one or more ribotypes. And so what I've just shown you is a snapshot of the right-hand end of this graph. And we see that what happened back in the nasty noughties, when we all became rightly obsessed with C. diff, is that we got very good control of ribotype 027, which is the black segments on these frequency histograms. But things have remained fairly stable hitherto, including during the pandemic. It's the numbers, the rate that's gone up, not that C. diff has changed. That's the message. And if you think, okay, is everybody else seeing the same increase in C. diff infection in other countries? Uncomfortably, the answer is no, according to the few publications available. Spain, US, the Netherlands. A hint, though, from the Netherlands that they've seen a significant change in sampling and requesting testing for C. diff during the pandemic. No great surprise, actually, is it? Again, because attention was elsewhere. And I have my suspicions, but can't prove yet. We are looking in great detail at NHS data as we speak at an institutional level to see whether there have been changes in the way we're looking for C. diff. So is ascertainment bias playing a role here? And ascertainment bias can work in two ways. One, if you don't look, you don't find. But also, if you don't look, things go out of control, certainly from an infection prevention perspective, and I'll show you some data in a second about that. As a lead into that, just stop and think. You know how frequent hospital onset diarrhea, defined under this table, how frequent that is. The headline rate, roughly 1 in 20 patients each day in hospital develops diarrhea, hospital onset diarrhea. That's a lot of diarrhea. Contrast that, just go back and do your maths for how many patients you have in beds, how long they stay, and so on. Contrast that with how many samples are submitted for C. diff infection, and I'll bet you'll see a large discrepancy. But also, and the only thing I want to concentrate on this slide is the bottom bullet point in bold text. If you look at those individuals in that large cohort, the largest ever cohort published on in the worldwide literature, by the way, an uncomfortable fact comes to the fore, which is that if you look at individuals who were tested for C. diff infection versus those who were not, they had no difference in the number of potential causes of diarrhea. And yet, what are we meant to be doing? Testing people for C. diff when there is no clear and obvious cause for their diarrhea. These data suggest that that is not happening systematically at all. These are old data, I think from 2017, and it was just a look and see. And I've acknowledged and thanked Russ Hope for the data. But basically, since the noughties, every trust has supplied every quarter the number of samples it receives, diarrheal samples it receives, and the number that it tests for C. diff. And we, Public Health, HBA, PHE, UXA, various iterations, have never done anything with those data on a formal basis. But things may change. But if you look, basically there's a spread in how much testing is going on and how much sampling is going on. And there is a loose association, pardon the pun, lots of puns when you talk about C. diff. It's a loose association with C. diff rate. But basically, we know in general, I can show you different data sets, I'm not going to today, that the more you test, the more you find. But basically, this variation in the extent of testing and sampling, can't test if you don't sample, sampling and testing, is unexplainable at present. So there is certainly a grounds for the theory that ascertainment bias is at play. Some of you may remember these words. They were a helpful hint, some might say threat, from the system as to what is going to happen next. I.e., we were going to start focusing not just on the headline rate from each trust, the numbers of cases, and giving a target and so on. We're going to start actually focusing on how frequently are you sampling? How frequently are you testing? Something called the pandemic got in the way, though. We never did it. I'm pushing to try and bring this back. Helpful hint. It won't be this year, it won't be next year, by the way, 23, 24. But it may be beyond. Just some data to show that if you look at different parts of Europe, look at their prevalence of a strain that is bad for you, the black segments on the graph, rabbit type 027, look at the rates of that, the prevalence of that strain, compare that with how frequently they are testing, and you find an inverse correlation. In other words, if you don't look hard enough, strains that are bad for you get out of control. That's not proof that one follows the other, but it's certainly very plausible. And whilst we don't have a lot of ribotype 027, thankfully now, if we're not detecting all the C. diff that's available, how can we be confident that we're preventing transmission? We know about antibiotics causing C. diff, obviously, but did you realise the exponential increase in risk of C. diff, not linear, exponential increase in risk as you move from one exposure to two and so on? And this is not at the same time necessarily. It could be sequentially, could be partly sequentially, partly at the same time and so on. But basically, just imagine if you could reverse that 25% increased risk from preventing someone getting their third or fourth antibiotic so that they only have two. You reduce their CDI risk by 25%. Pretty good incentive, isn't it, I think? I think patients would be interested to know that each time an antibiotic is contemplated, wherever the contemplation starts. These are old data where at the bottom, purposely chosen, and new data at the top with exactly the same message. Unnecessary antibiotic surgical prophylaxis, and that doesn't necessarily mean giving it when it's not indicated, but giving more than is indicated, is clearly associated with excess C. diff infection risk. I'm not going to have a go at Giles, who, by the way, gave a brilliant talk earlier on. If you draw up league tables, and these are not easy to draw up, and they're full of caveats of high risk, medium risk, low risk C. diff infection antibiotics, then you get something that looks like this. And we're all aware of this. But the only reason I put this slide up is to emphasize one point here, and that is that you can see fluoroquinolones appear in two different parts of this league table. And that quite simply is because it isn't simply a case of high-risk antibiotic. It's what are the C. diff strains circulating in my unit, my hospital, my community? Because in this instance, if you've got, and this is population-based data, if you've got fluoroquinolone susceptible strains circulating, the ones in blue, then a fluoroquinolone restriction policy, national policy, makes no difference. They remain the same. Because it's the resistance trait of the strains themselves that give the advantage to C. diff. And in that case, the resistant C. diff strains, ribotype 027 and others, in red here, then a restriction policy is very successful. Very briefly, some data about community C. diff. We don't do enough, I think we would all be honest to say, about investigating, understanding and intervening with community C. diff infection risk. Why is it that study after study after study across the world finds something very, very similar, which is about a third of patients in the community who develop C. diff infection have not had prescribed antibiotics recently? So why? What's causing the C. diff infection? If you're waiting for me to tell you the answer, I don't know. We don't know. We don't know if it's antimicrobials in the food they're eating. It's almost certainly not illicit antibiotics in the bathroom cabinet. We don't know if it's other things, PPIs and so on. Unlikely to be PPIs on their own because the magnitude of risk of PPIs causing C. diff compared with antibiotics is much, much less. But this is something we need to understand. Basically, we wait for C. diff to come to us in hospitals and we study it. We're not very good at going out and finding it and studying it in the community. I've got, I think, is it one slide, two slides to mention on C. diff treatment. The talk is about management, broader than treatment, 4 sets of guidelines. The only thing all 4 sets of guidelines that have recently been introduced agree on is that metronidazole is no longer to be recommended as a treatment for primary CDI. Okay? It's the only thing. I'm not going to talk about the other controversies on here. I just wanted to get that message across. It's clearly an inferior antibiotic. We know that now for the treatment of CDI compared with the others available. Vancomycin's not on here, but it's clearly inferior to vancomycin. And the reasons why metronidazole is inferior are listed here. This is not an exhaustive list, but the metronidazole doesn't even get to where you want it to get to in the lumen of the large intestine, and particularly on the mucosal surface of the large intestine, which is where C. diff is doing its bad business. It has very poor pharmacokinetics. And then there's a whole host of other reasons, including emerging resistance mechanisms, which I'm not going to go into here. Sorry, I've jumped one slide. Lastly, I just want to highlight some data which I don't think got enough airplay, because we published this in 2018. It's just off the slide at the bottom here, unhelpfully. But then stuff happened, and before we had chance to promulgate the data. But we looked from a large data set in Leeds, and this work was done by my friends and colleagues in Oxford alongside our team. And we identified the risk factors for transmission of C. diff and the risk factors for acquiring C. diff, and they're very, very similar. And there's only one difference, male sex, there to add to the others that are independent risk factors driving donation, poor term, but nevertheless we'll stick with it, or receipt of C. diff. So if we can focus on those, we're focusing on the sitting ducts for acquisition or donation of C. diff in the hospital setting. Easier said than done, I realise. Does it matter if people donate C. diff or receive it? Well, of course it matters. We're back to Rose's avoidable infections, but look at the outcomes associated with receipt of C. diff from another patient. Significantly more likely to recur, and just the good side of significantly more likely to die. But that's probably just a quirk of the not enough patients in the data set. I just wanted to highlight this point as well. That is that it's real C. diff infection with toxin present in the feces that is the main risk for donating your strain to somebody else, as opposed to being PCR positive. It doesn't mean that if you're PCR positive, you are no risk, but you are 3 times less likely to donate your strain to somebody else who will get C. diff infection than if you are a CDI case with free toxin. So my take-home messages are here, and I'm not going to read them out for the sake of time, but I think there's absolutely more we can do to A, refocus, take a breath, pardon the pun, from respiratory control, refocus on C. diff control, because look at the harm that is being caused by C. diff. Preventable harm that is being caused by C. diff. We got down to a level. Was it an irreducible minimum? I don't know. I don't think it was, but actually 25% more than where we were is bad news. So we need to refocus and take the data that are available on where we should be focusing and go there. Thank you for listening.